I am very pleased to have Dr. Dupuy-McCauley here with me from the Mayo Clinic in Rochester. She is a board certified in pulmonary critical care as well as sleep medicine, and has spent a lot of time focusing on classification of hypopneas and has published in this area. And I'm very thankful that she's willing to share some of her research and where she sees the importance of this in light of some of the newer therapies today. So thank you so much for joining us this evening.
Thank you so much for having me. I'm really excited to be here. As you know, I love talking about hypopneas, so always excited to share about that. Let me go ahead and share my screen. This is always somewhat of a challenge here, but give me 1 second. Okay, there we go.
Looks great.
Okay, perfect. All right, so thank you so much, Dr. Germany and Jamie, for having me tonight, and thanks to all of you out there in the internet who are with us tonight. I do have a disclosure. I do some consulting work with Respicardia, and I will be talking about the phrenic nerve stimulator, the remedē device. We're going to talk a little bit about central sleep apnea in general, and then we are going to discuss how important it is to distinguish hypopneas that are central from hypopneas that are obstructive and the reasons for that. And then we also have some exciting new information to present to you about the impact of classifying obstructive and central hypopneas. So most of you probably know this, but sleep apnea is just repetitive breathing pauses that occur at night. So these can be decreases in airflow, which we refer to as hypopneas, or an absence of airflow, which is an apnea. And we have central apnea and obstructive apnea. In central apnea, these episodes of reduction or absence of airflow are not accompanied by respiratory effort. And so most of the time they are occurring because of a lack of the drive to breathe. Whereas in obstructive apnea is occurring because there is actual closure of the upper airway, and so upper airway obstruction preventing air from passing. And typically in an obstructive apnea, the patient is still trying to breathe, and so there is still respiratory effort present. And so when you look at a sleep study, you will see here is an obstructive apnea. There's very little airflow here. And if you look at the thorax and abdominal bands here, you'll see that the patient's still trying to breathe, but no airflow is occurring. If you look at a central event, there's no airflow here. And these two are the abdomen and thorax bands, and there's also no effort. So the patient is not trying to breathe. Most of the time, the airway is still open. It's just that there's no input from the brain to create respiration. So why is this important? Well, I guess one of the reasons that I really like treating central sleep apnea is that there's still a lot that we have to learn about it. What we do know about central sleep apnea is that, a lot of what we know has been discovered in the population of patients with heart failure. And we know that people with central sleep apnea have worse outcomes. And so it's definitely associated with worse prognosis. But we don't know much about the clinical outcomes of treating central sleep apnea. And this is just more outcomes data here. So in addition to having worse mortality, people with central sleep apnea who have heart failure are more at risk for hospital admissions. And so this is such a common condition. It's becoming more and more common as our cardiovascular therapies are becoming more sophisticated. And so more and more people are going to go on to be diagnosed with central sleep apnea. And so we need to get our act together and find out how best to treat it, because it is a targetable thing that we can do for patients to improve their quality of life. And I'm hoping that one day we understand exactly what we need to do to improve their outcomes and mortality. So the main risk factors for central sleep apnea include age. It's more common in men. As I mentioned before, it's very common in heart failure. and atrial fibrillation and some other cardiovascular conditions, also stroke, renal failure, medications. Opioids would be the most common medication. And then there's a handful of other diseases that it can occur in, such as spinal cord injury. Symptoms are pretty vague. A lot of patients will have excessive daytime sleepiness or insomnia, or just generally saying that they have poor sleep quality. There's also symptoms that can be related to oxygen desaturation or waking up in the midst of these events. So some people tell me that they'll wake up from sleep feeling really short of breath or feeling like they're taking these big breaths, probably because they've just had an apnea and now they're taking these larger resuscitative breaths. So that if they wake up in the midst of that, that might be perceived as dyspnea. And then some people can have morning headache, nocturnal angina, or even arrhythmias, although that's a little bit less common. And then the bed partner usually has a little bit of trouble describing what they're seeing at night. A lot of the time I find that people emphasize sometimes I have to reach over and poke him to make sure he's still breathing. That's a really, really common one as well. The best way to diagnose central sleep apnea is with a polysomnogram, so an in-lab sleep study. We also now have home sleep apnea tests that can distinguish central from obstructive events. So peripheral arterial tonometry devices or PAT devices. And then there's also type 3 home sleep apnea tests, which are the ones where people come in and you put a couple sensors on them and put a band around the chest and a band around the abdomen, and then you send them home and have them sleep. So those types of sleep tests also can measure central versus obstructive events. But diagnosis at home is not always as accurate as diagnosing a patient in the lab, because even when we're looking at the full data from a polysomnogram, sometimes it's still hard to distinguish which events are central and which are obstructive. And then the other thing is that because there's a lot of different flavors of central sleep apnea, if you will, patients respond really differently to the various treatments that we have for central sleep apnea. And so an in-lab polysomnogram will give you the chance not only to make an accurate diagnosis, but hopefully to also get a sense of what kind of treatment they may respond to. And then of course there's insurance reasons, which unfortunately we have to consider also. And so a lot of the therapies that we have for central sleep apnea won't be reimbursed unless you have documentation in the lab, or some of them at least. This is the important thing to document when you're making the diagnosis. So there's some sort of symptom. The patient has at least 5 or more central apneas or central hypopneas. So either apnea or hypopnea, they are both given equal weight. And then the central component of the disordered breathing has to be at least 50% of the total number of disordered breathing events. So they can have some obstructive apnea, but in order to give them a diagnosis of central apnea in the eyes of insurance, you have to have more than 50% centrally mediated disordered breathing events. And these are all the diagnoses of central sleep apnea that we typically give. Again, it's a group of disorders. It's not really one thing, which makes it all very complicated. There's probably a lot of different phenotypes of central apnea that we are not completely appreciating. And again, it makes therapy a little bit difficult because people respond differently. So you can have primary central sleep apnea, which is sometimes called idiopathic, or meaning that we don't have any clear cause of the central apnea. And then there's secondary central sleep apnea. Sometimes this is with Cheyne-Stokes respiration, as we see in heart failure. It can be due to high altitude periodic breathing, treatment emergent central sleep apnea, which happens in patients who have obstructive apnea on baseline, and then we put them on positive airway pressure therapy and they develop central apnea. There's central sleep apnea due to a medical disorder without Cheyne-Stokes breathing. So that might be somebody who has central sleep apnea because of a stroke. And then central sleep apnea due to a medication or a substance. And most commonly, this would be opioids, but there are other medications that can cause central sleep apnea, like ticagrelor and valproic acid and muscle relaxants that are a little bit less likely to cause than opioids. If we compare the therapies that we have for central sleep apnea to obstructive sleep apnea, you will notice that there are more for obstructive sleep apnea, which is very sad because, as I mentioned, there are so many different types of central sleep apnea, and there's not a one-size-fits-all treatment. So it would be ideal if we had a whole toolbox of treatments for central sleep apnea, but that is not the way that it is. We have positive airway pressure devices, some of which are limited, meaning that, well, specifically the ASV has been studied in patients with heart failure with reduced ejection fraction less than 45% and was found to increase mortality. There is some data that has come out since then that suggests that that might not be a worry. However, the study was stopped early, and so we definitely don't have all the outcomes from that study that was supposed to have been done. And so I think that most people's practice is to still avoid ASV in patients with heart failure with reduced ejection fraction. And then we have phrenic nerve stimulation, which is a newer therapy, which I'll talk a little bit more about in a minute. There are some pharmacological therapies, including acetazolamide, theophylline, and actually buspirone. And there's a couple other ones too that have been investigated in a limited manner or are about to be investigated. And then oxygen as well. But the literature is very scant on those. We don't have any outcomes data about mortality or quality of life or anything like that. And the response to oxygen therapy and to pharmacological therapy varies widely from patient to patient. Again, as you might imagine, with there being so many different etiologies of central sleep apnea. And to further complicate things, it's usually not pure central sleep apnea. Obstructive sleep apnea is so common, and risk factors for obstructive sleep apnea like obesity are so common that most people who have central sleep apnea also have some component of airway obstruction. Of course, not all of them, but a lot of them do. So patients with obstructive sleep apnea usually have minimal amounts of central sleep apnea. And so that's another thing that makes therapy for obstructive sleep apnea a lot more straightforward. But then, you get a central sleep apnea patient and, they could have half and half. So again, this is part of the reason that it's so important to really understand what is going on, because you need the right therapy for what is going on. So how do we actually tell if a person has central sleep apnea? You would think that it would be very straightforward, but unfortunately it is not. So central apneas, this is what I showed you in the beginning of the talk. These are straightforward. I don't think there's much controversy. You have at least 90% airflow reduction that lasts at least 10 seconds, and there's no respiratory effort in the thoraco-abdominal bands. Central hypopneas, on the other hand, are less defined, and they carry equal weight in the diagnosis of central sleep apnea. And so the practice up until now has traditionally been to score the apneas and either ignore the hypopneas, or it was also a very common practice to just presume that all of the hypopneas are obstructive and just classify them all as obstructive no matter what. And hypopneas can be a significant proportion of the AHI. Sometimes they are all of the AHI. And as you can imagine, if you're not classifying hypopneas in a patient who has 80% or 100% of their breathing events are hypopneas, you're going to not know what their diagnosis really is. The definition of hypopnea has changed over the years many times. And it changed again, I think it was about a year and a half ago. It was pretty recent. And now we have two different definitions of hypopneas. We have the recommended definition, which is at least a 30% reduction in airflow using the nasal pressure transducer or the positive airway pressure device flow or an alternative sensor. It has to last at least 10 seconds, and it has to be associated either with a 3% oxygen desaturation or an arousal. And this henceforth will be referred to as the 3% rule. Then we have the optional definition, which is the same reduction in airflow and the same length, but it is associated with a 4% oxygen desaturation, and there is no arousal criteria. And I will refer to this as the 4% rule. And the most recent recommendation from the American Academy of Sleep Medicine is that we have to put both the 3% and the 4% results on the sleep study. And the reason that you can't really choose one is that Medicare and Medicaid only accept a diagnosis of sleep apnea based on the 4% rule. And there has been some argument about whether we should be strictly on the 4% rule or strictly on the 3% rule. We were changed to include the 3% rule because there are a lot of commercial insurances that do recognize that. And there is a large population of patients who have all of the classic symptoms of obstructive sleep apnea or sleep apnea, and they don't qualify for therapy because their AHI is too low, even though they're very symptomatic and they would benefit from therapy. So the point of including a 3% desaturation rule is to make it a little bit more liberal and capture more patients that would benefit from therapy. However, most of the research that we've done about cardiovascular outcomes has been with the 4% rule. And so there's going to be a little bit of muddy waters as far as, when we're using the 3% rule, where is the cardiovascular risk, and et cetera, et cetera. So that is the backstory on hypopneas. Another bit of history is that we used to have the advantage of esophageal pressure monitoring. This used to be really common in sleep labs, and esophageal pressure monitoring, basically you use a balloon that goes down into the esophagus, either through the nose or through the mouth, and it measures transpulmonary pressure, which is a surrogate for respiratory effort. And so here's an obstructive apnea, and you see the esophageal pressure monitor is telling you that there's increasing effort throughout this event, but still no airflow. So you know that event's obstructive. And if you look at a central event here, you can see at the esophageal pressure transducer, there is no such effort there. However, this has fallen out of favor. Not surprisingly, most people don't want to swallow a balloon into their esophagus on any night, much less during a night that they're already attending a sleep study, which is usually not people's favorite thing to do. And so I think there are still a couple of sleep labs that use this method, but most do not. So we don't have this benefit of having this, hard evidence of respiratory effort. And so if we want to differentiate hypopneas, we have been using visual criteria only. And that is what the American Academy of Sleep Medicine has recommended. They have stated that classifying hypopneas is not mandatory, but if you would like to do so, you can use this visual criteria. So they say that if the hypopnea has flattening of the inspiratory portion of the nasal pressure transducer, if there is snoring during the event, or if there is thoraco-abdominal paradox or the chest and abdomen bands moving in opposite directions, then that event should be classified as an obstructive event. If it doesn't have any of these characteristics, it should be classified as central. And this method has not ever been fully validated. And there have been other ways that people have tried to classify hypopneas over the years, and there is a little bit of research in this area. So we've looked at pulse transit time, we've looked at machine learning algorithms, we've looked at using inspiratory time and visual assessment of flow limitation, and chest wall surface EMG. However, none of these is in regular use right now, and probably because it involves using extra equipment that most people don't have available in a regular polysomnogram. So none of those has caught on. So we still have yet to discover the best way to classify hypopneas with the tools that we have now. Randrath and colleagues proposed adding a couple more visual criteria to the AASM criteria. So they proposed adding sharp termination of the event, arousal right when the ventilation resumes, and events occurring during stage REM sleep as additional criteria to let you know that it's an obstructive hypopnea. And I was part of a group that compared the AASM algorithm just using these three aspects to Randrath and colleagues' algorithm. And what we found is that both of those methods were about the same when it came to sensitivity and specificity and accuracy. So it seemed to us, at least from our assessment, that adding those 3 items was not necessarily enough to make a really good diagnosis of a central hypopnea. The specificity wasn't horrible. You can see that the specificity is 0.8, but the sensitivity leaves something to be desired. And, you know, the accuracy is okay, but it would be better if it were higher. Since this time, there's been another paper by Javaheri, Rappaport, and Schwartz, and they recommended even more visual criteria that you could potentially use to diagnose or to differentiate between obstructive and central events. So for obstructive, and some of these are included from previous, but if the AHI is worse than REM, you know, not always, but a lot of the time that's going to be obstructive. If there's snoring during the hypopnea, again, not always, but more of an indication of upper airway narrowing. Thoracoabdominal paradox, abrupt resumption of ventilation at arousal. And that's really because in an obstructive event, the patient's airway is closed. When the brain sends the signal to wake the patient up, their airway opens all of a sudden and they take a really deep breath. And so there's just kind of a sharp termination. Whereas a lot of the time with central events, they gradually get shallower and shallower with the breathing, and then they resume breathing slowly. Then if there is inspiratory airflow limitation during the hypopnea, more likely to be obstructive. And if there's prolonged inspiratory time, so if you look at the time of inspiration over the total time of the breath, if that is getting longer and longer, that implies that the patient is having to use more and more effort and taking more and more time to get the same amount of air through a narrow airway. And then to know if something is a central hypopnea, well, if the patient is having a ton of central apneas, obviously that's not a perfect way of knowing, but you know, if most of them are apneas that, or most of the apneas are central, then maybe these are central hypopneas too. If you have crescendo, decrescendo breathing, like you would see in Cheyne-Stokes respiration, that's more likely to be central. If the termination of the event is gradual, so there's not that single resuscitative breath, but the patient is gradually increasing the amplitude of their breathing coming out of the event. If they wake up at the peak of their ventilation rather than the end of the event, that's also more likely to be central. If the oxygen desaturation comes really far after the event, that is a sign of prolonged circulation time, as can be seen in patients with heart failure. So again, more likely to be central. And if the oxygen zenith is occurring in the midst of the hypopnea, that is also a sign that it could be central due to prolonged circulation time. I actually pulled this from a sleep study that I was reading this morning because I thought it was such a good example. But this is a person who had obstructive sleep apnea. And I thought this was a nice illustration of a hypopnea with some obstructive features. So in our configuration here, inspiration is this downward inflection. And so you can see that the patient has flattening of the inspiratory portion of the nasal pressure transducer, indicating airflow limitation. And then as they are breathing, this, I'm sorry about that. Whoops. As they are breathing, this inspiration is getting longer and longer and longer and flatter and flatter and flatter until they have this giant resuscitative breath all of a sudden at the end of the event, and the patient wakes up right at that same time. And so these are all things that are very suggestive of an obstructive hypopnea. And here's another hypopnea that is more consistent with a central event. And you can see this person's breathing, and then their airflow diminishes. Along with that, proportionally to the decrease in airflow, the effort also diminishes. And there's not much effort in the end of this event. And then when they come out of the event, they actually don't have an arousal from sleep in this case, but the emergence from the event is a lot slower here. And so again, these are features that are more consistent with a central hypopnea rather than obstructive. So why are we talking about all of this now? Obviously, central sleep apnea has been around for a long time. Hypopneas we have known about for a long time, and the AASM has not mandated classification. But now more than ever, in addition to not delaying therapy and getting the insurance right and all of that, it's important because now we have implantable therapies. And so if somebody wants to consider an implantable therapy, you have to be really, really, really sure that you are giving the right device to the right patient. Not only because you don't want to implant somebody with a device that they don't really need, but also to manage people's expectations. In a lot of cases, as I mentioned previously, people with central sleep apnea do have some component of obstructive apnea. And so when I see patients who I'm talking with about giving them an implantable device, I usually will have a conversation with them that, you do have mild obstructive sleep apnea in addition to your severe central sleep apnea. And, I want you to know that you might need an additional therapy for your obstructive sleep apnea, even after we treat your central apnea. You just want the patient to know what they're getting into. And it's not uncommon for people to need an oral appliance or CPAP on a low pressure or something like that to treat the obstructive component of their sleep disordered breathing. And so it's really, really important just for prognostic issues to counsel people on what they can expect for the future. So here are our two implantable therapies for obstructive and central apnea. I am, obviously this is talk about central sleep apnea, so I'm going to talk about the remedē device. So this is an implantable system that is approved for moderate to severe central sleep apnea, and it actually gets floated through the venous system here and sits next to the phrenic nerve, and it stimulates the phrenic nerve, which activates the diaphragm and creates contraction of the diaphragm, and so that generates a breath. This is what it looks like when it's implanted in the chest here. Here's the stimulation lead right there. And it can go into the pericardiophrenec vein, or it can go into the brachiocephalic vein. And the therapy turns on automatically. You set a window, so if the patient sleeps from 10 to 6, then it will turn on at 10 p.m. if the patient is lying down. And then it can be paused if the patient rolls over or if they sit up, if they have to go to the bathroom or something like that. And you set an amplitude, so how much voltage you're giving with stimulation, pulse width, how long the voltage is occurring, and then the frequency, which is generally really the breath rate. And this is what it looks like with the therapy off. So here, this patient is having this nice, kind of crescendo, decrescendo pattern here, and some episodes of apnea. And then once the therapy is turned on, they are breathing at a regular rate, their oxygen stabilizes, and hopefully they're not having any more sleep disruption or anything like that. And we have very promising data about it so far. This is data about improvement in sleep stages, basically showing that you're getting more deep sleep and less light sleep, and that has been sustained at 5 years. This is particularly exciting because we don't have a lot of data showing that many therapies for sleep apnea are improving quality of life, but it seems that patients did have an improvement in their Epworth Sleepiness Scale and quality of life, and 95% of them were willing to undergo the procedure again. So that is a good sign as well. And obviously there were some safety events, as with all procedures, but most of the events were mild and associated with site discomfort or discomfort with the stimulation from the therapy or lead dislodgement. And all of these events were able to be fixed. So the most important part, though, does it treat central sleep apnea? And the answer is it seems that it does. So here is the baseline. This green is central apnea, the gray is hypopnea. So just hypopneas of any kind. They were not initially scored. And then mixed apneas and obstructive apneas. And if you look at the baseline in 5 years, you can see that the central apneas are, basically gone. There's some increase in the obstructive component, but the most prevalent are the hypopneas here. And so myself and Dr. Germany and some people on her team recently decided to look more into that and see what are these hypopneas and why are they there. there have been suggestions for the reasons for residual hypopneas despite their remedy. So is it that the hypopneas present at baseline were obstructive and therefore the therapy is not going to treat them? Is it that there are some limitations in optimizing voltage due to patient tolerance of the voltage? Is it that there's a ramp up at the beginning of the night? There are some pauses in therapy as the patient's getting up to go to the bathroom or things like that. And so, are they more likely to have some hypopneas during these transitional periods? And then just anecdotally from discussions, is it that the phrenic nerve stimulator just doesn't treat hypopneas? So we went back and looked at the pivotal trial data, mostly white men, average age of 65, which is kind of the cohort that's most at risk for central sleep apnea, so it makes sense. And a lot of people had heart failure. And we gave a core lab the original PSG data from the pivotal trial and asked them to score the hypopneas. The hypopneas were originally scored using the 4% criteria, just to put that out there, and we had them classify them as obstructive or central. So these are the criteria that they use to classify the event as obstructive. So if the patient was snoring, if there was flattening of the nasal pressure transducer, and if there was thoracoabdominal paradox, increased respiratory effort without a concomitant increase in flow, abrupt termination of the event with deep inspiration, or progressive prolongation of the inspiratory cycle, like I showed you with that one example. So if that condition was met, then the hypopnea was classified as obstructive. And then if there was synchronous reduction in airflow and respiratory effort, symmetrical fluctuations in the cardiorespiratory signals, so this kind of waxing and waning pattern, a similar desaturation and resaturation slope for the oxygen, waxing and waning of the airflow, respiratory effort, breath sounds, crescendo snoring that occurs after the event rather than abruptly at the termination of the event, arousals at the peak of hypopnea rather than at the abrupt termination of the event, as would be more common in an obstructive apnea, a prolonged respiratory cycle length, which, as we discussed before, happens a lot in patients with heart failure, and if they had 2 or fewer flow limited breaths at the end of the event. They were considered mixed if they had more than 2 flow limited breaths at the end of the event. And what we found is that the residual median central apnea index and central hypopnea index was 1.9 and 0.8, and there was an 89% reduction in central events. 81% of the people went from having a central apnea hypopnea index of greater than 15 to less than 15, so going from moderate or severe into the mild range. And then the residual median obstructive apnea index and obstructive hypopnea index were 4.2 and 5.5, which is a small increase from the baseline. And then there was a reduction in the mixed apnea hypopnea index as well, which went from 3.6 to 0.2. And this is a visual representation here. So the blue is the central apnea index. So you can see this went down a lot. This is the control group. So this is the treatment group here. So the central apneas were really treated well. These are central hypopneas, and those actually were addressed well too. The obstructive apneas and the obstructive hypopneas increased. And there's been some theories about that too. People gain weight over time, things like that. Granted, this was a six-month follow-up. And we also got information about the responder rate, which I think is really important for counseling patients on, how what to expect with the therapy and how likely they are to get a good benefit from it. So if you have less than 50% of central events at baseline, it was 37.5, more than 50%, 61, more than 80%, 67, and more than 90%, 76.5%. So if the common practice of assuming all of the hypopneas were obstructive had been used for this, only 63% of the patients who qualified in the pivotal trial would have qualified if we had used that criteria. Recall that in the pivotal trial, the hypopneas just weren't scored and weren't included in the equation. 95% of the patients had a central AHI of greater than 15 per hour, compared to 73% of patients with a central apnea index. So basically adding that hypopnea component qualified more patients for the therapy. And then there was a 30% difference in the percentage of central apneas versus the percentage of central hypopneas. And so this actually goes against, I think, what some people assume, in that, you know, if you have all central apneas, then most of the hypopneas are going to be central as well. Interestingly, we did not find that it was as strongly correlated as I thought it would be. And we're not the only people to look at this. There was another recent study by Pepin and colleagues who looked how classifying hypopneas in a cohort of patients would influence the proportion of patients that were diagnosed with central sleep apnea. And when central sleep apnea was defined based only on the central apneas, and the hypopneas were considered obstructive by default, the presence of central sleep apnea was 4.59%. And then when classifying the hypopneas as obstructive or central, the presence of central sleep apnea was fourfold higher at almost 20%, so 19.69%. So again, it really makes a big difference if you classify hypopneas as obstructive or central in getting people a diagnosis of central sleep apnea. So the conclusion from all of this is classifying hypopneas is important because we are now considering implantable therapies, and we don't want to mess it up and implant somebody with a device that is not going to work for them. And also we want to be able to counsel them appropriately as to what they can expect from the outcome. And we should also be making sure that all the patients who are eligible are actually getting treated, because according to that research, there's probably a lot of eligible patients out there that are, you know, not getting therapy when they could because their hypopneas are not classified. And then again, predicting treatment response is important as well. And I wanted to talk briefly too, there was a recent panel that talked about central sleep apnea, you know, diagnosis and treatment, and kind of some of what we know so far and what we need to learn in the future. And they basically concluded that, you know, now being that we really don't know a lot about the clinical consequences of central sleep apnea and the outcomes of treatment, the therapies should primarily aim to alleviate symptoms, which again is really great that we know that the remedē device does seem to improve sleepiness and quality of life, because that's, you know, the main thing that we know is going to happen with therapy for central sleep apnea with the phrenic nerve stimulator. But therapies in general should aim to reduce sleep fragmentation, reduce awakenings, and reduce daytime sleepiness. And then also we should strive to control the underlying cause of the central sleep apnea, as with patients who have heart failure. But they also talked a lot about hypopneas, and they basically made a strong argument that hypopneas need to be classified to fully evaluate the impact on clinical outcomes, because if we're not accurately classifying patients to begin with, how can we, you know, understand what, if we don't even know if they have central sleep apnea or not, for instance, you know, how can we understand the impact of diagnosing and treating them? And then the other thing that they brought up, which I thought was really important as well, is that phenotyping patients with central sleep apnea may be really helpful. And there are probably a variety of ways that you can do that. Again, as I mentioned before, central sleep apnea is a group of disorders. It's not one thing. People have varied responses to therapy. And so, you know, do you split patients up based on the type of central sleep apnea that they have? Do you look at them by their response to therapy? You know, they mentioned understanding airway mechanics and using that as part of a way to phenotype people. Or, you know, taking everybody with a certain disease process who has central sleep apnea and looking at that. And so again, you know, I don't think that you can just ignore hypopneas in the future, because this small body of research that is just coming out now really suggests that they make a big difference in getting an accurate diagnosis. And so if we ever want to get to the point in research that we want to, where we really know the outcomes of central sleep apnea and the impact of treatment, I think we need to find an agreed upon way to classify hypopneas. And so those are basically my conclusions. We need to classify hypopneas. All right, thank you very much. I wanted to leave some time for questions. And so let me stop sharing my screen here.